adnexal examination because the eyelids and lacrimal system are part of adnexa. So the eyelashes of the lower eyelid are turned in. Excellent. What are the other findings? Nodular swelling just below the eyebrow.
Is oops.
It is told in the primary case. MRD appears to be right.
Excellent. So dermatological changes in the skin of the right eye. So what do you think? What is the cause? If you compare the skin of the right eye with the skin of the left eye, is there any difference?
Orbital fat collapse, eye appears to be sunken and deep with probably due to collapse of the orbital fat.
Okay, so, right. So, but there is usually because of the trichiasis. So next question is, what is the provisional diagnosis? What could be the serious consequences?
Senile entropion.
There is entropion. So what are the consequences?
Corneal opacity, sir.
Corneal opacity, corneal heaviness.
Good.
Corneal ulcer.
Corneal opacity. Excellent. And what is the temporary treatment?
Tapping of the lid, sir. And lubricants. Lubricants and
good.
Bandage contact lens.
Excellent. So lubricating eye drops, bandage contact lens, and
taping of the eyelid.
Okay. So I would like to divert your attention to the skin of the lower eyelid. See, there are many folds in the skin, small, so seems to be as having slight dermatitis. This is not the case in the left eye. So continuous watering in the right eye has called an element of dermatitis, and this in the long-standing cases leads to cicatricial element also, right? So the main findings are entropion and the ptosis, but there is also slight dermatitis of the eyelids. Okay, so coming back to what is the definite treatment?
Senile entropion's Weiss procedure.
Sir, we can.
Good.
We'll do such a Weiss procedure, sir.
Weiss procedure is one option. Any other option?
John's procedure.
John's is
There is
another
a
option.
temporary.
Good. Temporary, yes, come up.
There is a temporary
what
measure we can take
LTS lateral tarsal strip, that is the laxity of the lip.
Good. So the most definite treatment and most effective, proven effective treatment is lateral tarsal strip with lateral tarsal strip addresses the horizontal lid laxity. What else do you require? There is an element of vertical lid instability. How will you correct that? Please.
The diamond incision.
Pentagon or diamond incision.
Pentagon axion or diamond axion will remove the element of horizontal lid laxity. How you improve the vertical lid stability?
So transverse everting sutures.
Okay, so everting sutures
Sir,
are
Jones procedure.
Okay, so I will show you. So lateral tarsal strip with advancement of inferior lid retractors is the best option that I consider. I've done about 200 cases in the last 5 years, and believe me, there is no recurrence. Previously, with lid everting suture and Weiss, we used to have with Jones and Quicket also about 20 or 30% recurrence rate. So excellent contribution from the audience. And now we come to another procedure. So what are the findings? Which common operation includes this step?
Elevator resection.
Good. Levator resection. So forceps are holding which thing?
So skin. Skin with ocularis oculi muscle.
Again consider, I am asking you about forceps. The forceps are holding a structure. What is that structure?
The forceps.
Levator epineuritis, sir.
Good, levator aponeurosis. And the lid speculum is holding which structure?
Sir,
Sir,
skin
lid speculum
with
is,
subcutaneous tissue.
Good. Skin and orbicularis are being held by the lid speculum while the forceps are holding the levator aponeurosis. And can you see in between anything in between the two structures?
Sir, is orbital fat and tarsal plate.
Good. So orbital fat is visible, and this orbital portion of the orbital fat is known as?
sir, it's called the pre-epineuritic fat pad.
Excellent. So this is called pre-epineuritic fat pad. When you incise the septum, this fat pad prolapses. So you are sure that beneath this fat is the levator aponeurosis. So just revise the term pre-epineuritic fat. You will remember it. Okay, so which common operation includes this step?
Sir, levator resection.
Good. So
Disinsertion and resection of the levator muscle.
right. So levator resection, very right, by external approach. So we are approaching the levator from the skin side. There is another approach, and that is called
Conjunctival approach.
conjunctival approach or the posterior approach. So what are the differences between the two?
So height is both in the both procedures the same, but the contour of the lid is better with the posterior approach.
Okay, so you can make the lid crease better with the external approach, while you can't sort of crack the lid crease with the help of posterior approach. Okay. Another thing is that larger levator resections are possible with the external approach only, not possible with the posterior or the conjunctival approach. Okay, what is the recommended minimum and maximum resection? So if a patient comes with very mild ptosis with good levator function, how much would you excise? What is the minimum amount of levator resection?
10 millimeter is
10 millimeter.
Okay, good.
Is
10
minimum.
millimeter.
And maximum is 25 millimeter.
26 millimeters.
Good.
Yes.
So 25 to 30 millimeter is the maximum. You really should not go beyond that. So excellent. So we move on to the next slide, and should be slide show. Right. So minimum 10 and maximum 30 millimeter. Now coming on to 12-year-old girl presented with watering, itching, and foreign body sensation. Both
Cobblestone, sir.
good. Cobblestone appear.
Papilla.
Papilla.
Giant papillae. Giant
Giant
papillae.
papillae.
I am still looking for a very proper term on this condition, which has an abbreviation also. Let's see who comes up first.
The GPC, giant papillary conjunctivitis.
Excellent. So basically the term is giant papillary conjunctivitis. And cobblestone appearance is the appearance, of course, these are giant papillae. So what is the differential diagnosis of the causes?
Contact lens wearer, sir.
Excellent. Contact lens wearer.
VKC.
Exposed suture.
Exposed suture. So if there is a protruding end of a suture, that will also induce this appearance. So what is the medical treatment?
Remove the stimulus which is causing it. First of all, remove the stimulus. For example, don't wear the contact lenses or remove that suture.
Excellent.
Or
Good.
Lubricating agents, mild steroids, anti-inflammatory agents, massless stabilizers.
Okay, so you have done all the medical treatment and the condition is still not improving. So what options do you have?
VKC, then supratarsal steroid injections.
Good. Anything else that you can do?
conjunctival autograft.
Conjunctival dissection, sir.
Actually, this is the a large papilla doing a mechanical sort of thing. So you can do cryotherapy with the giant papillae. So good response, excellent. Have you mentioned the role of contact lens, a bandage contact lens or rigid gas permeable? That can also avoid the foreign body sensation and the itching in the cases. Naturally, you require lubricants and all the antihistaminic and the steroid drops. Okay, so coming to the next case, 5-year-old girl presented with painless mass right eye. What is the provisional diagnosis?
Dermoid, sir.
Dermoid, superficial dermoid cyst.
Dermoid cyst, sir.
So now is the more important part. What are the characteristics to be noted during the examination?
So whether it is adherent to the subperiosteum or it is mobile, it is not adherent to the periosteal.
It's fixation to the underlying tissue for any
extension into the intracranial.
Excellent. So you want to see whether it is communicating intracranially, and how would you know that?
Through the
So
CT
we'll move
scan or X-ray orbit. X-ray orbit or CT scan through the
CT scan.
Good. So you will ask the radiologist to help you to find if there is any bony gap and there is any intracranial component also, because it can be dumbbell shaped. There can be one portion of it inside the cranial cavity.
Yes, sir. Dumbbell shape.
Right. So what about, would you like to see its consistency?
Yes, sir. It can.
Hard or semi-solid, cystic.
Okay.
It's a choriostoma, sir. It's a choriostoma. Yes, sir.
Excellent. So actually, whenever we encounter a swelling or a nodule, first of all, we describe all its characteristics. So whether it is firm or rubbery or some soft tissue mass, and then we see whether it is painful, tender or not. And thirdly, we see if there is any palpable pulsations, and then we auscultate for bruit. So you have to be thorough with your approach. Inspection, palpation, auscultation. Whether it is a straightforward case of dermite, which is present in this case, but you will always like to pinch the skin over the swelling. You would always like to move the swelling on the underlying tissue. You will always see for its consistency, transillumination, whether it is tender or not. And the third thing is in not in children, but in adults and in old age people. One more thing, in the presence of any swelling, just like this one.
Lymph.
Hello.
So lymph nodes.
Lymph
Lymph
nodes.
nodes.
So lymph nodes.
Excellent. So whenever there is a swelling around the eye in the middle age or the elderly people, you always go for the lymph nodes to see whether.
Preauricular and
Excellent. So preauricular and
Submandibular.
submandibular, submental and submandibular.
Deep cervical.
Excellent. Very well done. So what is the treatment?
It says excision in toto.
Excision in toto.
Excision and toto.
Okay, so what is the harm if it is not excised in toto?
It causes the spilling of the keratinized tissue that causes intense inflammatory reaction in the surrounding tissue.
Excellent.
Like orbitocellitis.
Okay.
Yes.
Dermatitis.
Very right. Actually, I have encountered 2 times such a case. Another surgeon operated and left part of it, and I had to remove the whole mass again. But the picture was just like an orbital cellulitis. This was so intense inflammation that it seems that there is a boil or an abscess. Rather, it was an incompletely removed dermoisis that had caused very sort of flare up of the inflammation. Excellent. So we move on to the, let's see the answers first and then.
Yes, sir. So the answer.
Okay. So smooth, firm, non-tender, immobile, dermoid, X-ray, CT scan. So lid deformity. The question was there any lid deformity and was there any globe displacement? So what do you think?
The lid deformity was there, but globe was not displaced.
Okay, good. Good observation. But why the globe displacement was not there? What was the reason?
Because it is superficial, it is not deep.
Good. So when it is present in the deeper tissue, then it displaces the eyeball. And the displacement of the eyeball is known as?
Dystopia?
Dystopia. Good. So how many types of dystopia are there?
Inferior dystopia, horizontal dystopia, vertical dystopia.
Good. Excellent. And what is the forward displacement of the eyeball?
Proptosis.
Proptosis. Excellent. So well done. Coming to the next case, 70-year-old patient presented with lower lid margin problem. What are the findings?
So there is a lesion in about 3 in horizontal lesion about 3 into 5 about 5 into 3 millimeter horizontally in the lower lid of the right eye involving the lateral side with destruction of the lower eyelid distinct with indistinct margins. There is ulceration of the lower eyelid margin and there is no bleeding.
Good. Loss of
eyelashes.
Excellent.
Loss of the contour of the eyelid. And I want to check the lymph nodes of the patient.
Good.
And I cannot comment on the edges of whether they are rolled or everted. I think rolled edges.
All right. So in addition to ulceration, is there any other element that you would like to remark?
I want to see pigmentation, sir.
Pigmentation and vessels, any telangiectatic vessels or any pigmentation.
Telangiectatic vessels.
Excellent. What is
most likely is a basal cell carcinoma, sir.
Okay, fine, excellent. So what is the total length of the eyelid from medial?
30 millimeters, sir.
30 millimeters.
30.
So if you consider 30 millimeter the total length, what is this length? The lien of the length?
It's
around 15.
More than 1/3, sir. More than 1/3.
Approximating about half, let's say 10 to 15 millimeter or something like that.
Yes, sir.
Yes, sir.
Okay,
Where to fit? Yes, sir.
so you have to remember the length of the eyelid so that you can describe it about more than 1/3 or slightly less than half. And what is the preferred treatment?
The Hughes flaps, Hughes transfer conjunctival flaps.
Excision properly with tensile, semicircular tensile flap.
Okay.
Excision with 3 to 4 millimeter normal tissue surrounding it. We'll do the complete excision, send it for biopsy, and do tensile flap for reconstruction. Tensile semicircular flap.
Excellent. So you see, you have to mention the name of biopsy. You want to have histological.
More micrographic.
Most biopsy of frozen section.
Good.
Standard frozen section and more micrographic.
More, if you have frozen section, any one of you having the facility of frozen section?
No, sir.
No, sir.
No, sir.
Okay, so what would be the best option in your hands?
The histopathological, we send it for the laboratory, Sokat Khanam.
Okay, so
histopathological finding.
you will send it to the histopathology, and what are you looking for? What help would you ask them for?
Clear
palisading at the periphery.
Clear margins.
Palisading at the periphery.
Good. So the basic thing you want to know is whether the margins of your resected tissue are clear of the tumor cells or not. So if they are not, then what would you do?
Further excision.
Further excision. Excellent. And you will send it to histopathology or not?
Yes, sir.
Yes,
we
we
send
will
it
send
again.
Good. So you will send all the excised tissue to the histopathology department till the margins are clear of the tumor cells. Right. So BCC is one tumor which is locally spreading and does not give rise frequently to lymph node metastasis. So you can be relaxed about that, but naturally the examination includes the lymph node assessment. Okay, which is the most common malignant lid tumor?
Basal cell carcinoma.
Basal cell
So,
carcinoma.
yes, one of our specialists in Hyderabad was of the opinion that squamous cell carcinoma is the most common, but for most Western examinations, you should mention the BCC is the most common malignant lid tumor. Okay, so term use is nodulo-ulcerative lesion occurring at the lateral portion of the inferior lid and involving the lateral canthus. Right. So next is describe the ocular findings.
There is prominence of the both eye and scleral show inferiorly in the both eye, and the both eye appears to be protruded, and the on the right eye, the medial conjunctiva is congested.
Good.
And yes, sir.
Medial conjunctiva is congested. Only medial conjunctiva. Are you sure?
Yes, sir. Medially more congested nahi hai.
Medial more congested. Yes. So now you are right. So medial is
Yes, sir.
more congested than the lateral portion of the conjunctiva. Anything else? Sorry, I missed your earlier sentences, but what were the opening sentences of people?
There is a prominence of the both eye and the scleral show inferiorly in the both eye.
Good. So there is scleral show. It seems that the eyeball is protruding forwards and the lid is a little bit retracted. Which lid is retracted?
So right lid, I think, is retracted.
Right eye, which lid? Upper lid or lower lid?
So upper.
Both.
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 Good.
Both are retracted.
See, normally the lid covers how much of the cornea?
2 millimeters of the upper cornea.
Upper lid 2 millimeter
So,
and lower lid lower limbus.
So, do you think that this lid is covering 2 millimeter of cornea?
No,
sir.
No, sir.
LMP sign is positive, sir.
So this meeting will end in 10 minutes and we will have to rush through the rest of the slides now. But tomorrow we will be sampling at 6 p.m. for corneal topography, right? And the day after tomorrow, I will try to have the OCT. So what are the
Okay, so
relevant
it's a
points?
same ID and same says Zoom ID.
I will try to make another ID, a new ID. I will communicate with you. So what
Okay,
are the 6 p.m.
Okay, so please and
What are the
okay, fine,
relevant
sir.
points in ophthalmic examination? What examination, specific examination would you like?
Optic nerve function.
Excellent. What optic nerve function? The most important functions of the eye. And what are those?
So
Visual
visual
acuity.
color vision,
Color vision,
confrontation, confrontation test,
confrontation,
simple reaction, sir.
and optic paler, optic disc.
and finding
Pupil
the
reaction.
pupillary reaction, finding after defect and the color of the optic disc. Is there any pallor or not? So what are the relevant investigations?
Set thyroid, TSH test,
TSH.
thyroid profile,
Good.
Thyroid profile.
Thyroid
CT
profile.
scan.
And CT scan.
Okay, good. So what would you find on CT scan?
So
Sir,
enlargement of the muscle.
enlargement of
muscle
muscle with tendon sparing.
Excellent. Enlargement of the muscles with
Coca-Cola
enlargement
bottle
of the-
sign, sir.
Good.
With
In
tendon
addition
sparing.
to that, anything else in extreme proptosis? What can be the CT finding?
Sir, straight optic nerve.
Okay, stretching of the optic nerves. Stretching of the optic nerve. Usually the optic nerve has a sinuous course, a zigzag course, but because of the proposed proptosis of the eyeball, there is straightening of the optic nerve. Good. So what treatment would you recommend?
Sir, lubricants, ocular,
Sir, thyroid.
Okay, first lubricants,
and sir, if
Treatment
there
of
is
the
thyroid
eyelids,
disease,
treatment of the eyelids.
treatment of the disease, sir.
treatment of the
Steroids.
disease. Good.
Of the disease.
So it will depend upon the activity score. If it is if it is greater than 3/7, then we can go for steroids, and if it is less than 3/7, it will be just lubricant and taping of the eyelid.
Excellent. So after steroids, the patient has not responded. What next?
The wall decompression.
Good.
Radiotherapy.
Okay.
So we can go.
Yes. You see, orbital decompression, if the medical treatment does not is not successful in an orbital decompression.
Can we go steroid sparing before orbital decompression, sir?
Radiotherapy.
You see, steroids have a role when the disease is active. When it is in cicatricial stage, there is no congestion, there is no redness, then steroids will not help. Then you will have to do an orbital decompression. Okay, maybe we have 1 or 2 more cases and we can come back to this. So what is this? After trabeculectomy on first post-op day, this is the condition. What are the findings?
Shallow anterior chamber.
Excellent. So the anterior chamber is shallow. Is it shallow or is it collapsed?
Sir,
It's about to collapse on grade 1.
Okay, so it is not collapsed. Excellent. So what is the differential diagnosis if IOP is 6 millimeter of mercury?
if it's sir, overfiltration.
Overfiltration.
Wound leak.
Wound leak. And how would you check the wound leak?
By Seidel.
Excellent. And what is the differential diagnosis if IOP is 36 millimeter of mercury?
The pupillary block and malignant
Pupillary block and
Malignant glaucoma, pupillary block, suprachoroidal hemorrhage.
Right. So, excellent. What is a malignant glaucoma?
Aqueous misdirection, sir.
Excellent. Aqueous misdirection syndrome. What is the treatment?
Due to a serial ventricular
atropine.
That is a
okay.
Adriatic disease.
Any surgical treatment? Or?
Vitrectomy.
Very good. Excellent. So that is the definite treatment. Let's see if we have 1 or 2 cases. So this patient had severe ptosis both eyes for which levator resection was done. And this is the post-op picture. What are the findings?
Right lid retraction.
Excellent. Right lid retraction. And what is the cause? Overcorrection. So what was he was operated in both eyes. Maybe the surgeon was wise enough to do the resection equal in amount in both eyes. Why the lid retraction is present in the right eye only? What could be the cause? Suppose I say that the ptosis was equal in both eyes and the surgeon has done equal amount of levator resection in both eyes. So why lid retraction in the right eye? Why not in the left eye also?
Overstimulation.
Is there increased innervation of the other eye?
No, first time I will have to say no, because you are forgetting another very important aspect of the lid. In ptosis, after the amount of ptosis, which is the second most important thing?
Levator function.
Excellent.
Levator function.
Yes, the person who has said levator function deserves distinction. Actually, this is the most important. You see, when the amount of ptosis is and the levator resection has been done equally in both eyes, so the only difference remains the levator function. Apparently, the levator function was not considered in the plan for the surgery, and the levator function was good in the right eye, and that's why there is an overcorrection. So, in 99% of the cases, you will notice in your future practice that the overcorrection is because of of good levator function that was not considered while operating. So at what height you will consider levator function? How much levator function is good and how much is not sufficient?
So your 25 millimeter is maximum.
Good. So if the levator function is less than 8 millimeter, you should leave the lid at the end of the operation slightly above at the limbus. If the levator function is good, you should keep the lid 4 millimeter below the limbus. For example, if the levator function is 15, once the edema subsides, the levator function will pull it up. Okay, so what is the treatment now? What would you like to do with this patient now? What is the remedy? Surgical management.
With the advancement.
Sir, we can do massage.
Good. So in the initial stages, massage or pulling the lid down. Once you mechanically pull the levator, stretch the levator, and there is possibility that lid will be relaxed by pulling it. If pulling does not help, then
the surgical correction.
we will wait for.
okay. So if the amount of retraction is more, then you do a reoperation. Right. So there is last 1 minute,
Yes, sir.
and we will see what is this. Only 1 minute left now. What is this?
Just to put which
There
is
is
causing
good. Causing?
lateral dystopia.
Lateral dystopia.
Excellent. So use these technical terms. Causing lateral dystopia. Excellent. And what investigation would you like to have?
The CT scan.
CT scan. And on CT scan, it was found that the sinuses are excellent. Mucocele. Another distinction goes here. So
Thank you, sir.
mucocele is the actually. So what is the treatment?
Excision, sir. Sag excision, sir.
Excision. Excellent. Right. So